Good morning, everybody. And for some of you, good afternoon or good evening, depending on where you are. My name is Ali Baj. I'm a spinal neurosurgeon here at Weill Cornell in New York City, and I would like to welcome everybody to this morning's session. As many of you know, we started this last week, and this is a brand new, novel, adventurous endeavor, if you will, where during these very difficult times, we're trying to bring people together who are passionate about spine surgery, and spine education. Please bear with us. This is a very complicated situation in terms of finding the right platform that is both safe and secure to do this. And as we saw last time, there were some glitches. There could be some glitches today or in the future as well, but we will keep doing this until we find the right platform for everybody. Just a few housekeeping rules. As you can see, most of the audience can participate with questions through the chat panel. Dr. Khoi Than and Dr. Wendy Gibbs, who are faculty hosts of this project, will be monitoring that. And this session is also being recorded. That is according to the requests of many of our participants, and especially the ones who can't make it. So this will be recorded and it will be published online, and I would like to make sure that everybody is aware of that. Without further ado, I'm going to introduce today's special presenter, Dr. Eric Elowitz, who's a partner of ours here at Weill Cornell, who is an expert in minimally invasive spine surgery. He gave a very nice presentation on spinal endoscopy last week, but there were a lot of follow-up questions that we could not get to. So we decided to do this special session this morning. So we go a little bit deeper into some questions regarding endoscopy. This is not your typical session. Our standard conference will still be held every Thursday at 5 p.m. Every Thursday at 5 p.m. Eastern Standard Time. So this is a special session that we may or may not continue to do in the future. We'll just see what the feedback from the participants is. So without delay, Dr. Elowitz, I'm going to give the screen to you, and feel free to take it from here, and we will start compiling questions about spinal endoscopy.
Okay, great, thank you. Thank you again, Ali and the other course directors. I'm going to share my screen. Is everyone seeing that now?
Yes.
Okay, great. So what we thought we would do is to give a short recap for just a couple minutes of some of the different spinal endoscopic approaches, show two quick cases, and then get right into the Q&A. Just in terms of some of the recapping, what we went over last week, the two basic endoscopic approaches. There's the interlaminar approach, which is very similar to conventional approaches. So just essentially almost a midline incision, slightly paramedian, and that's really very good for paracentral herniated discs. At L5S1, it really is very useful because of the wide interlaminar space, not necessary to drill at all. The transforaminal approach is unique to endoscopy, where the incision is made about 10 centimeters lateral to the midline. And this is not only useful for foraminal pathologies, but also can be used for paracentral or central herniated discs. Interlaminar approach, again, very similar to our standard approach for either laminectomy, laminotomies, even laminectomy for bilateral approach. In terms of patient positioning, I do this under general anesthesia, although many people will do it under awake or a slight sedation. Patient is prone on the Wilson frame on the Jackson table. Just some of the techniques, tips on interlaminar approach that I mentioned the other day is it's very helpful to keep the skin incision small. Not only we wanted to keep it small just for our patients, they like small incisions, but more importantly, when we do the operation, we are doing this under continuous high pressure irrigation. And if the incision is too big, a lot of the irrigation just leaks out through the opening. However, it's very helpful to keep the fascial incision wide so it doesn't limit the mobility of the tube that we use. Just a little bit in terms of targeting, it's very similar to targeting microdiscectomy, particularly a tubular approach using both AP and lateral fluoro. Something I was talking about the other day, I just want to make myself clear on that, is that we have a outer working sleeve that is inserted and that has a bevel. Through this sleeve is where the endoscope is inserted. So the working sleeve itself, because of the bevel, can be used as another tool by turning the bevel at different points, particularly in the interlaminar approach, allows for the mobilization and retraction of the nerve root. There's always a lot of questioning about how to open the ligamentum flavum in the interlaminar approach. What I use is a micro punch where one aspect is blunt. So I think this video shows that well. It's important to really clean off the ligamentum flavum extremely well. There's often fat, muscle, and it's worth spending that extra couple minutes. Then using this punch, place in the blunt foot of the punch and then snap it closed. Sometimes, particularly at 5-1, where there's a very thickened ligamentum flavum, it's necessary to do this a few times in order to gain access. As you can see now, you're starting to see epidural fat even dura, and then using a Carrison punch, resect more of the ligamentum flavum laterally. And just as in a tubular case or open case, I like to resect the ligamentum flavum to the lateral aspect of the nerve root so that I'm not overly manipulating the nerve root or risking a dural injury. This is an example of a case where we can remove a very large herniated disc. Occasionally these disc herniations so large they don't fit through the working channel, so can remove the entire endoscope but keep that sleeve, which I showed before, in place, so it becomes very easy to get the endoscope right back in. Do not have to start from the beginning. And then the interlaminar approach is also very well suited for laminectomy, and this can do the so-called over-the-top approach, whereby we undercut the spinous process to do a contralateral laminectomy from an ipsilateral approach. The transforaminal endoscopic approach is somewhat different. This is, again, where we're coming in laterally and taking advantage of the Camon's triangle area. A point of concern is always the exiting nerve root. You have to remember the exiting nerve root comes out high in the foramen, just below the pedicle of the upper vertebral body. So when we're targeting, we want to target low in the pedicle, at least initially, and then possibly use the reamer to open that area up. This can be done under sedation. I do this on the general, but many people will do this awake. If I do this on the general, then I do use intraoperative monitoring. So the structures to be concerned about are the exiting nerve root, there's a traversing nerve root, Camon's triangle region. When we're targeting the SAP of the lower bone, and then potentially using a reamer, and then placing the working channel and then the endoscope. This is an example of a paracentral, slightly inferiorly extruded disc herniation, and this could be approached with either interlaminar or transforaminal approach. Nice thing about the transforaminal approach is do not have to drill any bone at this level at 4-5. If we're doing an interlaminar approach, would have to probably drill part of the laminotomy. And the transforaminal approach is also very well suited for a foraminal pathology, such as this foraminal slightly far lateral herniated disc. This is after placing the working channel, working sleeve down. Again, we're low in the pedicle because the exiting nerve root is higher up. Showed this the other day, a paper we published where we use a continuous EMG, continuous EMG monitoring, but also a nerve stimulation to identify the exiting nerve root. And another aspect of the case I showed the other day, this is very well suited for patients who have adjacent level, there may be a herniation, and we or the patient not favoring extension of the fusion. We could do a transforaminal approach, avoid any of the scar tissue to address foraminal pathology. I'm just going to show two quick cases that didn't show the other day, highlighting some of the aspects of both of these procedures. Case one is a 72-year-old man, about a year history of severe right anterior thigh and knee pain. He underwent a right L3-4 laminotomy in another hospital, but he continued to have pain. And if we look at, these are the sagittal images, the mid-sagittal view is not bad. If we look at the left sagittal view, the foramen is open to the nerve root with the fat around. However, when we look on the right side, there's significant foraminal narrowing, disc herniation, and this is what's clearly causing the compression. So it's not surprising that a laminotomy did not help this his pain, because it's very hard or nearly impossible, a laminotomy, or sometimes what we call foraminotomy, which is really a lateral recess decompression, to decompress pathology that's truly in the foramen, as in this case. I tend to also look at the coronal x-rays, or in this case, we had a coronal MRI scan, and just to make sure that there's not a scoliosis. Someone asked the question the other day whether the endoscopic foraminoplasty would be helpful for patients who have scoliosis and foraminal narrowing. My experience is it's not that helpful. So I think that looking at the coronal images, either MRI or X-ray, is important, just to make sure that we're not dealing with a deformity case. So this is, again, the image is showing the stenosis. So I thought this was very good for a transforaminal microdiscectomy. Really wanted to make sure it reamed open that foramen as well for the nerve root decompression. The other case is a 37-year-old woman with 6 weeks of partial left foot drop and lower leg numbness. She has a L4-5 herniated disc with an inferiorly extruded fragment behind the body of L5. This is the sagittal and axial images. So right at the level of a disc, it really looks pretty good. But as we take successive images downward on the axial images, you start to see the disc herniation and compression of the nerve root, and particularly here. Now, I think this case could be appropriate for a transforaminal approach, but I felt because it was herniated so inferiorly, even just medial to the pedicle of L5, I wanted to do a interlaminar approach. It was necessary to do a laminotomy to drill, because that interspace is not as wide as at 5'1", and then resect a little of the bone lateral recess, make sure that I'm lateral to the, or medial, I should say, medial to the pedicle to remove that extruded fragment. So I think after that recap, we can open this up for questions and answers.
Great, wonderful. Thank you, Eric. That was a nice summary and a recap of both last week and the new cases that you presented. So just as a reminder, as some folks got in a little bit later, for obvious reasons, we can't unmute everybody's mics. That would not be valuable, but feel free to type in your questions in the group chat. And Dr. Khoi Than, who's with us today, one of the faculty hosts, will be fielding questions from that group chat. And also as a reminder, again, a few people logged in a little bit later, this session is being recorded and it will be placed online. So please be mindful of that. And obviously participating with us is your consent to be part of this program. And Eric, while we start fielding some of the questions from the audience, and I know we talked about this a little bit last week, which is for some of us that do the minimally invasive, say, laminectomy or discectomy through either a very small 1-inch incision or even smaller with a tube, And you've done it all. You've done, you know, small incisions, tube, now endoscopy. So you're, I think, the right person to ask this question. What is the biggest advantage of saying doing this endoscopically and taking the time to learn it and struggle with it initially versus just going down with a 14 or 16 millimeter tube? It's still an elective, it's still an outpatient procedure. It still takes about 1 hour or less, very effective. What, what do you think the difference is?
I think in terms of the interlaminar approach, I can't say there's going to be a huge difference. It's nice, particularly at 5.1, we don't have to do any drilling whatsoever. So I think that if we're worried about, not that I think it's a destabilizing procedure, but even still, we don't have to do any drilling at 5.1. But the cases where I've had to go back, if they've had a recurrent herniated disc a time later, it's definitely less scar tissue with the interlaminar approach. And again, I think the biggest benefit is, what really is a game changer, is the transforaminal approach. Many endoscopic surgeons who I know barely do any or don't do any interlaminar approaches. They do everything transforaminally. And I think in my practice, I'm starting to do more transforaminal even at 5.1, but I still love the interlaminar approach at 5.1. Patients who have a large extruded disc herniation. It's very quick. You know, again, I don't think it's a huge advantage compared to tubular. But again, if my philosophy is always, if we could do something in a less invasive and a smaller way, that's better. Plus, there's new technology that's going to be emerging and is emerging now. There's multi-port endoscopy, potential of fusions, so that if we want to get to these more complex cases, we're going to have to, as individuals and as a field, be able to do the more straightforward cases before we move ahead. We want to learn how to walk before we run.
Great, Dr. Elowitz, there's some questions from the audience. The first one has to do with patients with obesity. Can you talk a little bit about both patient selection as well as technical nuances for patients who are on the larger side?
That is something that we all face in our practices, and really for obese patients, this is absolutely ideal. In the same way that tubular discectomies are often easier in obese patients than, let's say, a more open traditional approach, endoscopic is even easier in the sense that the space of the actual working sleeve and endoscope is fixed. So it really doesn't matter how much is out of the patient versus how much is in the patient. Unlike tubular, where you have to use different size tubes and can get more challenging once you get to 8 or 9 centimeter tube, the size of the endoscope or the distance of the endoscope is fixed. So it really does not make a difference. For the transforaminal approach on a larger patient, would make the incision a little more lateral than on a thinner patient. I may add an extra centimeter or 2. And for the particularly large patients with it, I can't say I've done that, BMIs of greater than 50, there is a extra long transforaminal endoscope that can be used. And that certainly would be far easier if you have to operate on a patient that has a BMI of 50 or more. Certainly a lot easier. Don't have to worry about fat. Infection rate is going to be low. We're not dealing with, not going to have seromas from the operation. So I think in obese patients, it's really has tremendous advantage.
There's a question from a Dr. Abdullah asking, would you do a migrating disc as a transforaminal approach for L5 to S1?
I would, particularly the inferiorly extruded discs at 5.1 are probably a little easier than the superiorly extruded discs, just because of the angle of approach. But it's very easy to do these operations with extruded fragment. Like in any discectomy case, really want to explore it. Once you remove the disc, or as much as you think you've removed, I think it's still important to use a ball probe to dissect around just to make sure there's no retained fragment. But the visualization, ability to remove multiple large extruded fragments is very very doable with the endoscopy.
Another question from a different Dr. Abdallah regarding whether you find the endoscope suitable for very large disc herniations or very, very severe lumbar stenosis.
Definitely for very large herniations, it certainly is a very good option. I think if someone has, let's say, caught equina syndrome, or we're concerned about that, I probably would do that tubular, if not potentially open, depending on the situation. I tend to do, even if it's a caught equina and from a disc herniation, to do that as a discectomy, not as a full laminectomy. In cases of really severe, really tight stenosis, I probably would choose to do a tubular, but certainly for most cases that, let's say, moderate to severe, I would be very comfortable using the endoscope for that.
Here's a.
I'm going to jump in if that's okay, Coy.
Yeah.
I see Dr. Alakad there, who's from a good colleague from Saudi Arabia. Dr. Alakad, I'm going to unmute you, and I think you, if you want to ask your question directly, and introduce yourself to the audience, of course.
Well, it's nice to see everybody. About how maneuverable is the endoscope. You know, I haven't used it, to tell you the truth. I'm using the tubular retractor, and I went through a curve where from open to micro, then to tubes, and then back to micro, to tell you the truth. I'm using the tubes only for a far lateral disc and for very obese patients. But otherwise, I want to know how maneuverable is this to be able to get into the angles and for the subligamentous disc and stuff like that. And what's going to happen, like for CSF leak, how can you avoid it? And if it happened, what would you do with it?
No, those are definitely good questions. In terms of the first part, in terms of how maneuverable the endoscope is, there's definitely a lot of latitude. That's the reason why I like, in the interlaminar approach, really want to make sure that the fascia, the deep fascia, is open widely. So I'll use an 11 blade. So my fascial incision is larger than my skin incision. So I'm not caught up with that, but you definitely can maneuver that into laminar. Transforaminal, part of it is maneuvering. There's not a lot of space within the foramen, but there's no issue, no problem moving the tube around. And also takes time, but do have to realize the endoscope itself is angled so that the visualization is either 15 or 30 degrees, depending on the approach. So that by turning the endoscope, you can get a better view at one area, particularly if, let's say, I'm doing a transforaminal approach and I want to look at the exiting nerve root, I'll turn the endoscope 90 degrees so I'm looking up, taking advantage of the angled view. In terms of CSF leak, I have had now 3 cases with CSF leak. 2 of them were, clear dural rents and use Duraform through the endoscope. Actually through the endoscope, then remove the endoscope, leave the sleeve, and then use Tisiel. And I've sent those patients home without a problem. Did have 1 patient where there was a nerve root extruding through the dura. Did my best to try to push it back in. It's really, we don't have the technique, the tools to primarily close the dura, which would be nice if there's a nerve root that's extruding. A patient woke up, had severe pain, so we did take the patient back for a laminotomy to do a primary closure. Although looking at the literature, there are some papers that have shown just by using the fibrin glue, that may be enough to push the nerve root back. I'd have to say, I think if this were to happen to me again, I would be more aggressive in terms of making sure the nerve root was back in. But it just in terms of just a basic dural tear or clear CSF leak at the time of surgery, just by putting in the Duraform and Tisiel is really adequate. When you think about it, there's no dead space that's there because the opening used for the endoscope is very small, so it'd be almost impossible for CSF to egress out through the back. patients could potentially have spinal headaches. I have not seen that.
Dr. Elowitz, there's a great question from Dr. Rodriguez Macias about the learning curve for these types of procedures. Can you comment on that?
Sure. I think a lot of people have that concern. Certainly was my concern going into this. Mentioned the other day that doing this in cadavers really simulates what we have in patients. The only difference is we don't have the bleeding, but that's usually not a very big issue with surgery anyway. And we can talk a moment about what happens with some bleeding. But in terms of the learning curve, I personally spent a lot of time in cadavers. I probably did 15, maybe 20 levels with both the interlaminar and transforaminal approach. And then when I went in to do this in patients, instead of just putting this on at early in the day and following it with lots of other cases or leaving it to the end of the day, it really took 2 days in 1 week, two endoscopic cases on the Tuesday, 2 on the Thursday, and that was it for that day. That way I didn't have to worry, have the pressure. All those cases went well, and really build up confidence after that point. The other, I think Dr. Hartle makes the point that Real Spine, one of the companies that does simulation on a model, is also very good for endoscopic training.
You commented a little bit on this in the setting of a CSF leak, but have there been any other cases where you've had to revise from endoscopic to microscopic or something else?
No, I have not. That was the only case where there was a nerve root that was extruding through a dural rent, and the patient woke up with significant pain.
Great. Someone's asking for your advice for new endoscope beginners with what types of surgeries to start with, and any other sort of tips and pearls.
There's a difference of opinion in that. My view, what helped me was to do this with an interlaminar approach first. The benefit of that is we know the anatomy. We've all done scores, hundreds and hundreds, if not thousands, of interlaminar discectomies. So we already know the anatomy, and then it's just a matter of getting used to the equipment, holding it, using the different tools that are available. So in my mind, for me at least, it was less of a jump as opposed to the transforaminal, where you also have not only the challenge of the equipment and the endoscope and the tools, but also an approach such as the docking, as well as the visualization of something that we're just not as used to seeing.
How often do you have to drill the facet or the pedicle in order to widen the foramen for the transforaminal approach?
It's my experience. It's rare to have to drill any of the foramen. I do use there's a reamer with a system that I've been using mainly, which is the Joymax system, where there is a reamer to open up the part of the lateral foramen. I found that to be helpful. I have drilled as well. You can definitely get very, very good drilling, good visualization, even drill the top of the pedicle if necessary.
Another great question from Dr. Rodriguez is if you could comment on the complication profile with endoscopic cases.
Mm-hmm. I think the complication profile is low. We reviewed the literature on this in terms of a CSF leak and dural tear is lower with endoscopy than with open or tubular microdiscectomy. I've not had any hematomas or bleeding, although like in any surgery, that's always a small possibility. Never had any kind of significant intraoperative bleeding as well. I don't think I've ever heard of infection with these as well. I think the number one risk, at least that I tell patients about, is the risk of a recurrent herniation. This is still a discectomy. The natural history of a recurrence is going to be the same with endoscopy as with open or tubular.
Great question from Dr. Ejaj in terms of whether you've encountered conjoined nerve roots. how to investigate that preoperatively and how you deal with it endoscopically?
Yeah, that's I think a great question, and that's something which we would have to be concerned about potentially, even if we're doing a tubular or open type case. Most conjoined nerve roots are at the 5-1 level. So whenever I do a 5-1 disc anyway, I always will look within not only the lower level, let's say at 5-1, but also at the upper level at 4-5, because you can see an outpocketing of the dura without a nerve root in cases of a conjoined nerve root. But still, it's not 100%. I do, when I'm doing a transforaminal case, I will look at those lateral sagittal images to really evaluate the foramen and look at the foraminal pathology, as well as to see where the nerve root is exiting, although it generally will exit high up in the foramen.
Can you comment on thoracic endoscopy?
Many people are doing that. In my practice, I have not done any thoracic cases, but my understanding, speaking with people who do that, really feel certainly for, say, a lateral, soft herniated disc, that it is a really very approachable operation with endoscopy. And they use a transforaminal type approach, not interlaminar.
I'm going to just jump in here real quick. Dr. Elowitz was kind enough to join us again today. I know he's got to run soon, but just one last question, Eric. A lot. Do you use neuromonitoring when you do the endoscopic cases? And if not, when would you recommend that to be used?
I don't use neuromonitoring for interlaminar cases. The only time I use it is for the transforaminal cases. With the transforaminal approach, I think there are particular concern of the exiting nerve root, so that if we're 4-5, be concerned about the exiting L4 nerve root. This is not for the initial docking and placement of the working channel and endoscope, but also while we're working to make sure that the nerve root is identified and safe. Many surgeons will do this under local anesthesia, or maybe a little mild sedation, and then they rely on the patient to tell them if they're having any kind of pain, because obviously that area is very exquisitely tender in terms of the dorsal ganglion. I think I prefer doing this on the general anesthesia, but we still need to know where that the exiting nerve root is safe. So we use continuous EMG monitoring, so that if we are near the nerve root or just touching it in any way, I'll be told. And also when I have the endoscope in and I'm looking at when I have the endoscope in and I'm looking at the presumed exiting nerve root, sometimes we could see it very clearly. Sometimes just see perineural fat, and I use a stimulating probe through the endoscope, which we fashioned, and start a low, relatively like 5 milliamps, and I go up to 10 milliamps, and that's also a very accurate way of identifying and confirming the nerve root.
Got it. Okay. Well, obviously, I want to thank you very much. I know we have to cut it a little bit short today in terms of the session, but we will do this again. We will definitely bring back speakers and presenters who present on Thursday if there are any additional questions for a separate Q&A session. And again, I can't really overemphasize the fact that this entire endeavor is evolving as we speak. We would love to get opinions, suggestions, critiques, comments. This is meant to be for the entire spine community, whether it's orthopedic surgeons, neurosurgeons, radiologists, pathologists, anybody that deals with spine. And for a lot of the colleagues and your colleagues who perhaps want to join, please let them know that we are trying to slowly open up the forum to as many people as we can. But these online platforms are very challenging, and they're fraught with cybersecurity issues. So please be patient with us. Very quickly, on Wednesday morning, we will send the email invitations for the link to the Thursday conference, our primary conference, which is Thursday, 5 p.m. This Thursday, we have two terrific speakers. Dr. Dan Shuba will discuss spinal tumors. from Baltimore, Maryland, and Dr. Nicholas Sempron from Spain will also be joining us and giving a talk on, actually a case on ankylosing spondylitis. So we will try to incorporate as many speakers and guests from really all over the world. This is really what the plan here is, to share different opinions from folks from throughout the different regions and different countries, so we can all learn something different. Everybody has our emails and my email. If you'd like to present, if you'd like to show a case, please email me. We would love to get you as one of the guest presenters. We're not calling them speakers because we don't want lectures here. These are discussions. So with having said that, I want to thank everybody again. Dr. Elowitz, thank you very much. Koi Than and Wendy Gibbs, who's behind the scenes there, are faculty co-hosts of this session. A terrific group of 5 or 6 of us here in the United States that started this endeavor, and hopefully we'll expand it, include colleagues from around the world. So without further ado, please be safe, everybody. Prayers are with everybody. This is affecting the whole world. And Wednesday morning, we'll send out invites, and we will hopefully see everybody again on Thursday at 5 p.m. New York time, which I know is a little bit late for some of you folks, but hopefully we'll get some of you back. All right, take care, folks.